Hello, and a very warm welcome to this Noigroup clinical discussion. My name is Joanna Taylor, and I am Director of Noigroup Europe. And I am joined this morning, or this afternoon, or this evening by Noigroup Teacher and my very good friend, Laura Rathbone. Welcome, Laura. It's great to see you. So, Laura is a pain specialist clinician and mentor to healthcare professionals worldwide. She brings a unique perspective to her NOI teaching, combining cutting edge science with compassionate, inclusive practice. So, Laura, would you just tell us a little bit about what you're doing at the moment professionally, please? Thank you.
I'm a specialist physiotherapist and have been now for around about 15 years, specializing in complex and chronic pain. I work psychologically informed by acceptance and commitment therapy, and I'm also a trainer in acceptance and commitment therapy. My current clinical role is a consultant in pain therapy to the OLVG Ziekenhuis, a hospital pain team here in Amsterdam, the Netherlands, which is a real privilege to have and to be part of the pain team here run by the anaesthetists and sort of embedded within that model. In addition to this, I'm an educator, activist for social justice in pain care, and together with my friend Christine Petridis, I run Pain Geeks. Pain Geeks is an international and multidisciplinary reading community for clinicians, therapists, and researchers who are wanting to deepen their knowledge around pain as a human experience and sharpen their academic reading skills. I love doing that because it's every time we sign on and go into one of the live group discussions, it's a bit like, I don't know, walking into the common room or like your work break room, and you just sort of have these great conversations about, your job and your life and what's coming through in the evidence. So there's that. So if anyone's interested in finding a reading community that's following the evidence and sharing the load, then head on over to Pain Geeks and find our free platform where you can find out all about our paid subscription Super Geeks, and get to meet us a little bit and get to know us. So that's what I'm doing.
Fab. Thank you so much. Maybe you want to drop the link to Pain Geeks in the chat whilst I just do the rest of the intro. If
Sure.
that's okay. That's cool. It's such a cool community. Laura is so passionate, just so passionate about her community, the Pain Geeks. So these sessions, the clinical discussions, are all about giving you a taste of explained pain and how to practically use it in the clinic. Some of you on this call today will have already done an explained pain course, and for those of you who have, these sessions are very much designed to reinforce what you will have already learned. But if you're new to explained pain or you're new to NOI, then this will give you a taste of what we cover in the core course. So Laura has two upcoming explain pain courses, an online one starting in October and a face-to-face one in Dublin in November. And for anyone that's interested in this, we'll be talking a little bit more about those at the end of this session. But for now, we're just going to dive straight in. So Laura's going to be talking for about 20 to 25 minutes. If you have any questions, please drop them in either the Q&A or the chat, and we'll monitor those. We will get to as many of them as possible, but we usually run out of time. So I would urge you to get your question in early. You've got a better chance of getting it answered live. And if you want to watch the recording of this session, you can access it in the NOI clinical discussion group, where you will find, I think, about 40 of these. They're completely free, and they're available to absolutely everybody and anybody that wants to watch them. So do subscribe to the channel and you'll be notified when we release a new one. So today we're talking about the essentials of explain pain and some key things that a clinician might benefit from understanding. So briefly, Laura, could you tell us what you're going to cover today?
Well, I think what we just start. This is the first one in the series, so I think it's an important opportunity for us to talk a little bit about what I understand modern pain science to be and why I think some of our traditional models sort of set us up a little bit for failure, and I think that's an important thing to know. Some of the things that I think are like the core principles of how I work and what I think is important. And yeah, I think hopefully just some tips and advice on what you might be able to start implementing and using tomorrow.
Amazing. Thank you so much. So let's kick off. Let's start with the foundations. What is modern pain science, and why should clinicians be looking to move beyond traditional biomedical models?
Right, I want to preface this. If this is your first time exploring pain science, then my advice is not necessarily to move away from traditional models straight away. I think they're a great foundation. Our basic science and reductionist approach has been helpful in giving people an idea as to some of the what is happening inside someone's body when they're experiencing just well, I mean, pain, but that's because our focus is on pain. But if your focus was on pleasure or joy, you would see some of the same neurobiology being involved as well. But it gives you an idea as to what's happening inside the body. The difference between traditional reductionist approaches, where they're trying to reduce a complex human experience like pain down to a singular mechanism, and sort of a more modern approach is that we're understanding that pain is the way we build subjective experiences, personal experiences is combined between sort of your own physiology, your physiology within its current environment and your physiology as it's learned over time and your sense of self as you've learned over time and all the things that you've gathered and all the data that you've experienced and that is part of how you experience pain. And so modern pain science is trying to take this more complex approach, and instead of trying to pull everything down to a single mechanism, it's embracing the fact that we probably can't do that in reality. We do need to have a more complex understanding of pain, and an understanding that we're working within the subjective personal experience, the field of that. And so it's not necessarily translatable from one person to another. So every time you're meeting somebody, you're finding out about pain for the first time because you're finding out
Mm,
about their pain.
mm,
So that's
amazing.
what I
Thank
would
you.
say.
Okay,
Yeah.
thank you. So one of the things we wanted to talk about today, and this is probably kind of getting really into the clinical application of it, is that we wanted to talk about elements of effective pain conversations. So could you walk us through some key elements of effective pain conversations as you see it?
Yeah, so I would love to take credit for all of my insights, but actually, it's the years of working with clinicians and supporting them towards being able to do this job that's helped me come down to these three principles. So, first of all, I think that you've really got to be passionate about this area of work.
Mm,
Pain is a really complex play area to work in. It's complex science, complex philosophy. It's a hard job, constantly bearing witness to somebody else's distress and somebody else's suffering and needing to continually develop your own skills in order to hold that place safely. So you're going to need to be
mm,
passionate about it. And if it's not there for you, it's not there for you. And if it is, great, embrace it, like bolster it, find people, pull people around you that's going to continue to celebrate that and help you keep moving into this space. Um, and like I think what comes after that is you're going to have to be quite brave because you're going to go into some really tough clinical environments and might have some really hard conversations with people. So being able to sit with distress and acknowledge your own human experience, so being brave with your own vulnerability and your own humanity, accepting that you're not perfect, you're going to make
mm,
mistakes, you're only human, I think is a really important way of being and principle in this field, and it's going to help make this work kind of sustainable. And then I think the other thing is patient. Many of us, I mean, I'm a physiotherapist. Not everybody on this call is a physiotherapist, so this might not apply to everyone. Um, but we're often brought up in a sort of culture of looking for fast change. I mean, physios, we want in session change quite
mm,
often, which is wild, really, when you think about what you're trying to achieve. So being patient and allowing the process of change to take the time that it needs is going to be part of a really important part of your work. So these are the three things I would say.
Okay, so you're talking about being patient there with your patient in front of you and allowing the process of recovery or improvement to evolve,
Or
to not expect
acceptance.
things to happen too quickly.
Yeah, yeah. These
Yeah,
are
yeah.
quite big things that, when you think about pain. I mean, the area that I work in is quite complex pain that is associated with trauma as well. And when and often we're working with population and groups who might experience like financial insecurity. There might be lots of other sort of social stuff going on, and we need
Mm,
to be able to tailor our expectations to set the person up in their system for success. I think that's where
sure.
I think we can be patient, but also patient with yourself, right?
Yeah.
Like one of the things I see so commonly in the clinicians I work with is that they're so desperate to learn all the stuff as quickly as possible. But
Mm,
pain isn't like it's not a weekend course. It's a career. It's a lifelong journey into trying to get a better understanding of, the what we do know about pain, because we know a lot, but what we don't know, because we also don't know a lot about how pain
mm,
is being experienced and generated and why. So be patient with that. Don't have these expectations on yourself that you're going to be able to answer all the questions, because, I've been 15 years in this job, and some of these questions that I get from patients still, I'm like, I don't know the answer to that.
yeah.
And
Yeah.
that's
Yeah.
okay.
Yeah, thank you. That's great. So interesting that you started there, rather, and that we're now going to move on to some more sort of practical stuff, but sort of creating that space, if you like, for yourself and the patient that's in front of you. It was great. So clinicians often struggle with, and this is not what we always get asked, but what do I say? How
Yeah.
do I start these conversations? So, and clinicians genuinely struggle with how to start these sorts of conversations. So, have you got any hints and tips or techniques that you could share that people may actually be able to take with them into the clinic about how
Yeah.
to start these conversations?
So, I mean, this question is lovely and I get it. It's a desire to find certainty within the uncertainty, right? So,
Mm,
and I think finding a starting place, if you're sat there thinking, well, if I just need to know how to start these conversations, that's going to be what you do for every patient, you're probably looking in the wrong direction. Um, but I do think that we probably have like I certainly have a couple of different ways that I might start and open up with patients depending upon what I think is the need of the person in front of me. Um, Quite often, because people come to me, they're referred, I have a referral letter. So one of the first things I want to do is show my patient, I know who you are. Well, I know I have your referral in front of me and I've read it, right? So I at least know what's on this piece of paper. I don't know all your story, but I at least know what's on this piece of paper. And I often will sort of reflect that back to them and I'll say, I've got this letter from your doctor and they say this, this, and this. Is there anything that you need to add, or does that feel like it's accurate to where you're at? Just to show someone that, like, I'm a bit more prepared. I know this person a little bit more about this person as they come in, and I've done my due diligence and I'm ready to keep listening. Um, I think there's a sort
mm,
of trend towards, and I understand where this comes from. There's a sort of culture now of asking this very open question. First of all, what's your story?
mm,
And I think that's a wonderful way of starting a narrative-based medicine approach with your clients or your patients. But narrative-based medicine is a skill that you hone over time, knowing how to pull out clinically relevant information from somebody's narrative is a
mm,
skill. And I think if you haven't done any work in that, and if you're quite new to pain, that kind of open question can feel really overwhelming really quickly. And you're just going to have loads of information, and you and your patient are going to start to get a little bit lost. So I often recommend to people who are relatively new into this area or who don't have narrative-based medicine skills to say, like, what is it that you need from this session for it to feel successful, for you to walk out of this door and feel you've been listened to and you've been part of the process. So I think for me, these are the tips that I would recommend. And as you get more skilled at understanding, what somebody might be like, where is the clinically relevant information in somebody's story, I think you can be a lot more open. But don't be surprised if you start with a really open question and feel lost, because I think that's quite understandable and quite normal.
Yeah.
And we do have limited time. Not many clinicians have got 2 hours to sit with someone and let them go through the full story. Most clinicians are working on sort of 30 minutes, 45 minutes tops. So if you need to
Mm.
say, in this session, this is what we can do, and we can leave that for next session, then that's understandable.
Mm. It's
Yeah.
so interesting that you actually try to sort of almost narrow that story down and give the patient the opportunity to almost set an objective for the session. I think that's really, really interesting. I know we haven't talked about this, but what sort of, and if you, I don't want to put you on the spot, but what sort of things that are people often hoping for out of the session with you, or how might that conversation have gone for you a little bit? By the way, Laura's dog's next to her. I can hear her.
Yeah.
We can't hear the dog, and you can just see that there was a little
No, she's
head.
barking. She's barking at me. So if I start to look stressed, you'll know why. Um, so I think what I feel many patients really want from me is they want to know that they're in a place where somebody cares about the fact that they have pain.
Mm,
They're not in a place where they're going to be dismissed or they're going to be disbelieved. They want to know that the person they're talking to cares and is interested in understanding how pain is affecting them and actually helping them, right?
yeah, yeah,
And I think that is quite difficult really as a clinician, because you might have lots of systemic limitations around you that make it hard to do. I
yeah.
just
We
feel
really
as
can't hear the dog, honestly.
God,
Does she
oh
meant
my
to come
gosh, she's
up?
she's very loud here. She's only 7 months old, so she struggles a little bit
We
sometimes.
honestly can't hear her at all.
Um, so yeah, so I think most patients really just want to know that you care about pain, which is why I say one of the most important things is going to be your passion. Because
Yeah,
if you're sat there disinterested, the patient's going to feel that, because you would, if you were a patient and you went into your GP, you were telling them about something, I don't know, whatever it is, and the GP was just not interested, you're going to feel that immediately.
100%, hundred
And
percent.
and so one of the most key things is finding a way to be interested in pain. Find the joy of pain, of chronic pain, of being a clinician that works with people in chronic pain,
Yeah,
because they are going to feel that and they're going to feel safer with you. And that is a really and you can't fake it, I think. If you're not interested, you're not interested. Do something else. But like, if you're
yeah.
interested, let them see that you're interested. And that
Mm,
doesn't mean you have to know all the answers. It just, be like, be interested in the fact that they've had pain for a long time and try and find
mm.
out about how that impacts on their life. Yeah.
Or spend time with people like you who are really passionate about it, and it rubs off,
I just love
doesn't
it.
I know. I mean, I've done your one of your courses, and it's like you come away and go, oh my god, you just make people.
I want to work in pain.
But it's so true, like people who are passionate about this,
Yeah.
it rubs off on you, doesn't it?
Yeah.
And I can hear it in your voice. You get going, and it just makes me want to know so much more from you.
I mean,
But
it's just
Laura, we
it's
need.
just wild. It's just wild though. But yeah, okay, we'll move
we're
on.
gonna
But
we're
yeah.
gonna carry on because I want to get through everything in the session. But so one of the things that we just wanted to touch on here was patients who are resistant to the education that you're trying to provide, the pain education that you're trying to provide, and they come to you just wanting to be fixed. How do you respond to that kind of scenario?
Well, I'm an acceptance and commitment therapist, right? So I love it when I see resistance because I know, okay, we're in a process of we're in the process of change, right? So resistance tells me we've hit upon some rigidity in the way somebody thinks or feels about pain, because that's what we're working with. And it's a sign to me that we probably need to observe the resistance in and of itself. So, and very often I'll say, oh, I feel like this is something you're not really ready for, or you don't really want to talk about. Is that right? And try to pull the attention to the moment of resistance, and try and pull out a little bit about what's coming up for the person there and then. Um, I think we have a bit of a tendency to try and give education before we've really consented to it, because we feel like it's a neutral thing to do, or it's an obvious thing to do, right? And that might not be true for the person on the other side of our
Mm,
communication dyad. So, so sometimes I think we perhaps need to spend a little bit more time consenting people to learning about pain, and asking whether they're in an emotionally safe place to do that. Because learning about pain can be also very confronting, and
mm,
isn't necessarily, it's not inherently good or inherently therapeutic to give people pain neuroscience information. And so I think we need to remember that this is a part of a therapeutic process, and the other person needs to have the space and time to show up willing in that therapeutic process.
mm.
Um, and I think that's where our therapy skills are really important. And when a person comes in and says, "I just want this to be fixed," I think we shouldn't be surprised by that. I think that we should be expecting that, because you would want that for yourself, especially if you'd had pain for a long time and it no longer makes sense, and you've been into the healthcare service to try and make sense of it, and no one's been able to, and you're on this
Mm.
journey. Um, so I think we should probably spend a little bit of time wondering what fix it means. What
Yeah.
would better mean, and recognizing that when someone says, "I want you to take this away," it's not necessarily a way of burdening you with the responsibility. It's a way of expressing desperation. Like
Mm,
they've been living with this for a long time, and they are now at the edge of what they can tolerate, and they're becoming more and more desperate. And we should acknowledge that that is a development in their journey with pain that we have to develop the therapeutic skills to support. Um,
yeah. And what does being fixed mean to that person?
exactly.
So important to think just beyond that sort of first level thinking, isn't it?
Yeah.
Yeah.
But,
Yeah.
like the likelihood is it means take my pain away. And so, and like that's the job, not to take
Mm,
away somebody's pain, because we can't necessarily do that, but we can support people in making changes to the way they understand their pain, to the way they are in their world and in their life, and to the way they're managing their pain and the various sort of like emotional and cognitive stuff that comes with that.
mm,
So I think let's not immediately put up our wall. Oh, they just want me to fix them, which I hear quite a lot, especially in MSK physio, which is a
100%.
really shitty culture that we've developed.
Mm,
Um, it's an opportunity for us to be like, oh wow, this person is really struggling to find a way out of this, and they're
mm,
looking to external sources all the time. Like that
yeah.
must be a very scary place to be, to not feel in control of your own body and your own experience. We can be
I,
compassionate to that.
I love the way that you turn that into actually opening a therapeutic door. Something that a lot of
Yeah.
clinicians would see as that door shutting is actually you've reframed that and you think about that as a way to actually explore, which is one of the things I love about your approach, Laura,
Mm.
always have. Um, okay, so mistakes. What common mistakes may we see clinicians making when they first start implementing explain pain approaches? Or maybe what would you have told young Laura when she first
Ah,
started working in this area? What would you go back and tell your younger self?
So I'm so glad I have the therapist that I have, right? So if anybody has seen anything I've done before, like the first thing I say is like, I have a psychologist who helps me with my own shit all the time. And like, I am loving so hard on baby physio Laura quite a lot at the moment because like, it's been a long process to get to here. I'm really proud of where I am, but I'm also really proud of where I've come from and how much
Mm.
my skill has changed and my knowledge has changed, how I am has changed. And I remember, I don't know if you like, I talk about this quite a lot, but there's a comment that I sent in to Dave years ago, I think like
Dave Butler,
2013.
Dave,
Yeah, yeah,
David Butler.
2013 on the Noigroup. I think I sent it in maybe a year or two after I'd done the course with him. And I was like, I've explained pain and they're still not getting it. And like you can still see this comment on Noigroup. If you put Laura Rathbone Noigroup in, you'll still see baby me being like, I've done all the explain stuff and they're still not getting it. What do I do? And Dave just gave me the best advice, and I still listen to this even to this day. Like he was just like, well, first of all, well done for trying because this is really hard, and like don't worry too much about being accurate. Like, and I think I sort of had this desperation to be super precise, and that's been great because I've learned a lot about the science and I am very precise in my language. You don't have to explain everything perfectly, right? So, like, it doesn't have to be perfect to be helpful. It can just open a door. And remember, there's another person on the other side of that. They also can go away and Google and explore and look and think and reflect. Um, so I think that's one thing I would remember. The other thing I would say is like, don't mistake your passion for the neuroscience of pain for like a clinically usable information for the person in front of you. Like I
Yeah.
definitely did this in the beginning. I was like, it's wild. You've got these receptors, and then like this can happen, and then if this goes there, then this can change how it processes, and that's incredible. And like I was so passionate about that neuroscience. I know, baby.
Hello.
That I wanted to like share it because I was so sure that this
Yeah.
was the thing that changed my understanding of pain. So surely this will change the person in front of me. And I forgot about figuring out where they were in their process. And I just mistook my passion for it being therapeutic. Um, and I
So
guess
true.
and I guess the other thing I would say is like pain neuroscience education is not the treatment. Pain neuroscience education is the tool. It's a way of supporting the process of cognitive and behavioral change, of experiential change, of building curiosity in this other person in front of you.
Mm.
It's not like a medicine. It's not a targeted approach. It's a way of supporting people towards understanding that they live with chronic pain, accepting that chronic pain is part of their life, that it might not be the same forever over time.
Mm.
Um, and it's a way of moving forwards with that.
Amazing. So
Um,
what I heard there, Laura, was that don't try to explain everything perfectly.
yeah, yeah.
Don't mistake your passion for neuroscience
As like
as
as the
your
therapy.
patients.
Yeah, exactly. Just
Yeah.
because you love it doesn't mean they
Just because you
are.
love it doesn't mean that they do. And it's not, it is part of the process rather than the actual therapy. So
Yeah.
it's a very, very important distinction to make. And I understand how David will have taken you through that very gently.
Right. And remember, it's only a part of it. Like, you've got this huge therapy toolbox that this is just a part
Yeah,
of. And it might help you when
100%.
the patient says, but why?
Yeah, yeah,
Yeah.
absolutely amazing. Right, I see we have a few questions, so we'll take a couple of questions,
Yeah.
and before we do a little summary and then wrap up. So
I know.
you have a little chat with your dog for a second whilst I have a look through the comments.
She's getting
Oh,
desperate. I don't know
I
why.
know.
I
She's
took her for a
adorable.
walk.
It's because your attention's elsewhere, I'm sure.
Yeah.
Okay, so from Francesco, physios involved in chronic pain are inevitably tapping into psychology and trauma to fill the gap left by psychologists not being accessible. The lack of training, support, and supervision comes with an obvious risk for patients and clinicians. That's maybe not quite a question, but have you got any comment on that, Laura?
Oh, yeah. So first of all, I think the I understand where this comment comes. The idea is that we should have a biopsychosocial, multidisciplinary approach to pain management. And
Mm,
when we feel like we're on our own, we feel like we're having to fill that gap. I think that there's an element of that that is true. And I think you feel that more in chronic pain services. I would say that as physiotherapists, we've always been working with the psychological sphere because we're always working in movement and engagement, motivation. And we're always working in behavior change because we're asking people to do something that they weren't doing before. So I think that we probably just, I mean, the work on understanding that physiotherapists should be psychologically informed started in the 90s. And we're still considering this new or radical. And that frustrates me in some ways from an education perspective, not from a clinician,
mm.
because I totally get why clinicians are experiencing this as new. But as educators, this should be core curriculum. But yeah, I think that we do need to acknowledge that when we're working in acquired disability or long-term conditions, we're also working in the stress and the social environment that that person is navigating. So we should be updating our skills and engaging, improving our psychologically informed ones.
Thank you, Laura. And then from Audrey in the Q&A, she said earlier in the session you suggested, I thought, not to chase pain change within the session. And Audrey says that this can empower the patient and create trust when you can show them change, perhaps using the bio as a trust bridge to the psychological aspects.
Hmm.
Comment. Thank you, Audrey. Good question.
I think it's biologically implausible to me that if you hold your and this I get from my great mentor Mick Thacker, right? Like if you're holding the space well, a person should be leaving your session having had a positive experience, and that's
Mm,
something that I would hope for, whether it's because they've had the space to cry, or they felt listened to, or whatever. You're starting to build the ground block for change and trust, the therapeutic relationship. Um, I don't fully understand the idea of using the bio because I don't know how you separate the biological from the psychological or the sociological because the biopsychosocial model was never intended to be separated out into these three things. The idea was to try and understand that pain is always biopsychosocial in its entirety. So to me, the way that we're framing some of these questions says that we probably don't fully understand the original work around the biopsychosocial framework. So I would definitely recommend people to go back to the work from the 70s by George Engel and look at the way he set that framework out as a complex systems theory. The way a person is experiencing pain is because they are biopsychosocial, not because of the way the bio influences the psycho and that's a sort of bastardization really
mm,
of how that beautiful framework was intended to be used. Um, so like I think what people, especially physios, tend to mean when they use that is they tend to mean like doing some kind of intervention or some kind of touch or some kind of manual therapy. But that isn't biological in isolation. It's
mm,
always being received or being experienced by a biopsychosocial human being.
mm,
Uh, and so if you're able to use touch or you're able to use movement as a way of bringing about a change in that person's pain, then wonderful. Like that's the dream.
mm,
But for many people, especially within those early sessions, you don't know that person's experience of pain well enough to predict what's going to make it worse
yeah.
and what's going to make it better. So I would say, let's not set ourselves up for feeling like we're not good enough because we need to understand this is really hard what we're trying to do. Um, let's allow ourselves to ease into it gently, be prepared for the fact that what we do might make stuff worse, and be hopeful that we might see some positive change. Um, but just take it slow and remember that a big part of what we're doing is modeling that we're okay that this person has chronic pain. right?
Mm.
You know, like imagine being a physiotherapist working in cancer and being so afraid of this person having cancer and constantly panicking when someone comes through with cancer. Like that just
Mm.
wouldn't work as a therapeutic space. Like you have to be able to sit there as a therapist and be like, okay, I know you have chronic pain. I'm not afraid. I know you're afraid and I know the
Yes.
people around you are afraid, but I'm an expert in this. I can
Yeah.
hold this. You can come
Yeah.
back to me next session and have had no change, and I'm not going anywhere. I'm not running. I understand why you've had no change, and I want to know more. I want to know more about that because that's going to help me make better decisions.
Amazing. Thank you, Laura, and thank you, Audrey, for that really good question that has allowed Laura to kind of freestyle a little bit there because this is I bloody love this woman.
I love you
She
too.
is so passionate, and unfortunately, we haven't got time to get to all the questions today. And I do apologize for that. But what we are going to do is we are going to take all the questions from the chat today, and we're going to use them to inform the topics for our next three lives. So, hopefully, we will actually be able to answer some of those within the upcoming live sessions that we've got with Laura. One of the themes that's been going through the chat today, which is absolutely superb, is Laura and just how refreshing it is that this is kind of that this is uncensored and
Oh
it's
yeah, I will
raw,
swear.
raw and very real and very honest. And that is what you get from Laura Rathbone, everybody. So we're just going to wrap up now. Laura is going to tell you what she thinks her three takeaways are from the session today and bringing that back into the idea of explain pain. So, Laura, give us your top three takeaways about from today's session and about explain pain. And then we'll tell you about her courses that are coming up, which you may like to learn a little bit more about if you want to learn more about this.
So, okay, so I think the most important thing for me is that explain pain is not a script. Explain pain is not what you say to patients. It was a psychologically informed, pedagogically informed approach to helping people change how they understood their pain so they could be empowered to be curious about, how they're going to manage it in the future, right? So the explain pain, the neuroscience that is held within explain pain, the original book, that was just the neuroscience of that time. So 20
Mm-hmm.
years ago, that was just the neuroscience that we had. And, Dave and Lorimer, they were working to figure out how do we get this across to patients in a way that empowers them. And explain pain is an example of how we can support people's learning and how we can support people's. What I see as a psychologically informed therapist is how we can support them towards cognitive and behavioral change, right? Which is
Mm.
really, really difficult to do. So that's the first thing. Explain Pain is not a script, it's not a curriculum, it's a therapeutic approach to supporting people to understand what we now know as pain specialists, which is different to what we knew 20 years ago when Dave and Lorimer first wrote the
Yeah.
book. So you're going to have to, alongside your understanding of explain pain and the therapeutic process of education, you have to also update your pain science knowledge because that has moved on and you're going to find new ways, new metaphors, and it's so much more than just telling people that like nociception isn't the same as damage or nociception and central sensitization are different and maybe in ways relevant, right? There's
Mm.
so much more to the experience of pain. A part of the limitation, I think, of the original book sometimes is that it really relied heavily on this sort of biomedical view of pain. And now, of course, we're moving more into embodied principles and we're using sort of modern philosophy to help us, I guess, integrate the neuroscience that we're learning and about pain in a different way. So
Mm.
so allow yourself to get creative. And also you're helping patients understand why they have pain beyond tissue healing, which I think is a really, or even in the absence of pathology or in the absence of any injury. Like, so we
Mm.
need to understand that's going to be quite confronting for a person. So imagine if somebody told you something that you knew to be true about the world was no longer true. And that's what we're holding when we're doing something like pain education. So I think these are the things I would
Amazing.
say.
Thank you, Laura. And we celebrate at Noi that we get people, we have instructors like Laura who are out there reading and digesting the latest understanding. So using Explain Pain as a foundation and then drawing in all this new information and then being able to teach people under that banner of Explain Pain, but really the most cutting edge, the latest understanding of where we are globally when it comes to treating people with pain. So, thank you, Laura. Thank you, thank you, thank you. For those of you who might be interested in doing a deeper dive into Explain Pain with the amazing Laura Rathbone, just going to tell you, we're just going to tell you a little bit about what you might expect. Laura's got two courses. She's got an online course starting on the 6th of October, which you can join from anywhere in the world. It is, you can join live and you can also access full recordings. So you can join live and then rewatch, or you can watch on catch up if you want to. And then she also has a face-to-face course in Dublin at the end of November. I've dropped the links to those into the chat. So if you want to click through, then please do. So, Laura, just very, very briefly, what's your approach to teaching that Explain Pain course?
So my approach to any kind of teaching is always that it needs to be slow in a way. Especially this is why I like the online version, because we can take time over the 4 weeks to take what you've learned in the sessions and apply it to sort of have that back and forth conversation with the group or with each other, and really hone in on your reflective practice skills, because that's the thing that's going to carry you over the years that you work in pain, hopefully, and the thousands of people that you're going to support and help as somebody that works in chronic pain. So I think the idea is like, we're going to learn, then you're going to go out to practice, and then you're going to return, and we're going to do that for 4 weeks. When I think about the face-to-face session, it's a different time frame, so that's a slightly different way of teaching. And you should know that when you make a decision, right? What are you looking for? What have you got space for? What can you do? And if the online 4 weeks is not something you can do, then a 2-day course can be very helpful. But even in that 2-day course, we're going to be really focusing on giving you the principles of how to support people through conceptual change and reach that resistance, and how to roll with it, and how to allow that to take space, and really focus on Explain Pain as a therapeutic process. It's a decision you've made for your patient based on your therapeutic knowledge, your therapeutic skill, your therapeutic experience. This is what you think is going to help this person move to the next way of managing their pain. It's not something we just give like as a sort of standard thing. It's an intersubjective, it's an interpersonal therapeutic process. And I think that's the key that I want people to walk away with.
Thank you. Thank you, Laura. Thank
You're
you
welcome.
for sharing your amazing expertise with us today. And thank you to everybody who has joined us live in this clinical discussion. Thank you for your questions. Thank you for your amazing comments. Thank you for your support. And thank you to anybody that's watching on replay that took the time to sign up to this. We hope you enjoyed it. Please, please, please go across to our clinical discussion YouTube channel, where you will find at least another 40 of these with different
Wow.
Noi teachers on loads of different subjects. If you want to know anything, you'll probably be able to find that out in there. And we just want to thank you for your really positive energy today, and
Yeah.
keep an eye out for the next one with Laura. It's going to be in about 2 weeks.
Thanks,
Thanks.
everyone.
Thanks, everyone. Enjoy the rest of your day. Take care. Bye.
Bye.